Our goals will parallel the framework and focus clinical questions that are answered with basic lung ultrasound. We'll talk about normal lung and how you know if you have the optimized view. Then we'll get into some higher level skills for pneumothorax evaluation, alveolar interstitial syndrome with B-lines, and finally, lung consolidation.
Before we jump into our talk, let's do a quick review on thoracic ultrasound and the anatomy you are trying to achieve. For those of you who would like a more comprehensive review, you can refer back to the introductory thoracic ultrasound lecture. As we can see in the above image, every thoracic ultrasound view should achieve the following anatomy. From superficial to deep, we first see the subcutaneous tissue outlined in yellow. Beneath that, the intercostal muscles are outlined in red, followed by the pleural line in blue, where we see lung sliding. Finally, the green lines, representing A lines, which are a reverberation artifact of the pleural line, equally spaced within the aerated lung. All of these structures are centered between two shadowing ribs outlined in white on either side. It is important to ensure that your probe is always perpendicular to the pleural line to optimize its appearance so you can better evaluate for any abnormality. The presence of A lines are indicative of being perpendicular, but you may need to also adjust your probe orientation depending on the contour of the patient's chest wall.
To ensure optimal imaging, gain and depth must be appropriately set to the pathology you're evaluating. For instance, when assessing B-lines and lung parenchymal pathology, your depth generally should be set to about 12 to 18 centimeters, aiming to place the pleural line in the focal zone. However, if you're concerned for pneumothorax, your depth should be decreased to really focus on the pleural line as the structure of interest. For gain, this should be optimized to where your pleural line is distinct and rib shadows are anechoic. Note that this might be lower than the machine preset for lung ultrasound.
Now that we have gone over the basic anatomy of our thoracic ultrasound, let's jump right into advanced pneumothorax evaluation. A basic evaluation for pneumothorax involves visualizing the absence of pleural sliding, indicating the separation of visceral and parietal pleural layers by air. If you visualized other adjuncts, such as M-mode or more advanced evaluations, are not necessary. However, when evaluation is equivocal for pneumothorax and you are clinically concerned, there are some other tools at your disposal that we will review here.
So, several tools that we can use to better exclude potential false negative and false positives for pneumo include these. Power slide. We know that power Doppler can detect subtle movement with good sensitivity. When pleural sliding is present, the movement will generate a yellow-orange Doppler signal below the pleural line. In contrast, when there's a pneumothorax, the visceral and parietal pleural layers are no longer apposed, with an air layer intervening between them, so a color signal will not be generated. One caveat is that because power Doppler is so sensitive, it's important to keep the probe steady with your hand stabilized on the chest to prevent motion artifact that can be mistaken as lung sliding.
Lung point is another great tool at your disposal when clinically concerned for a pneumothorax. It is a finding that is considered to be pathognomonic for pneumothorax with very high specificity. So what is a lung point? In normal aerated lung, the visceral and parietal pleural are continuously opposed, which gives the appearance of pleural sliding. For patients who have a pneumothorax, the visceral and parietal pleural become separated, and on thoracic ultrasound, you're able to visualize this dynamic point known as a lung point. As we see in the clip here on the right side of the screen, we see pleural sliding that moves into view with respirations. In contrast, on the left side of the screen, we see no pleural sliding, which is where our pneumothorax begins. Of note, the location of a lung point is dynamic. For example, in a patient sitting upright, air will rise, and you can imagine the lung point being present closer to the apex, which is the area you would want to scan, while a patient who is supine, you would want to scan the anterior aspects of the chest. Lung point is also a valuable tool when evaluating for progression and size of a pneumothorax. The location of the lung point on individual's chest wall has been shown to correspond to the relative size of the patient's pneumothorax. Studies have shown that as the lung point location progresses from sternal to lateral and posterior, this corresponds to a larger pneumothorax size, with the mid-axillary line as a reference for a roughly 15% lung collapse. Although a CT scan is the gold standard for evaluating the size of a pneumothorax, it is not always clinically indicated, and the exposure to radiation that patients have does not allow for continual monitoring of a pneumothorax in this manner. Lung ultrasound has been shown to be a more sensitive imaging modality when compared to a chest X-ray in quantifying the size of a pneumothorax, with the caveat that similar to most ultrasound studies, it is operator dependent. Evaluating for a lung point allows clinicians to rapidly and with no radiation exposure track and evaluate a patient's pneumothorax and help determine should an intervention be necessary or not.
While ultrasound is a great tool for pneumothorax evaluation, knowing the potential false positives is important. There are many well-known causes of absent lung sliding, like blebs or bullae in patients with COPD or patients who are post-pleurodesis. But even a highly specific finding like lung point may have pitfalls. This clip shows a physiologic lung point. This appearance is thought to be related to the presence of the fascia endothoracica, which is the layer of connective tissue covering the inside of the chest wall and separating it from underlying parietal pleura and mediastinal tissue. It's often seen near the sternum at the level of the fourth or fifth intercostal space. At the physiologic lung point, the mediastinal pleura meets normally aerated lung and the pleural layers that slide adjacent to it. In this clip, you can identify normally sliding lung on the left side of the screen by noting the A lines beneath it. However, on the right side of the screen, in the area below the fascia endothoracica, A lines are missing. Instead, you see a pulsing pericardium and myocardium appear on the image. This can mimic pleural sliding and be mistaken as a lung point. Another potential mimic of the lung point is the curtain sign, which is very routinely seen at the posterolateral lung bases as the pleural line appears and disappears at the costophrenic recess through the respiratory cycle. In the clip, the sliding of the pleural line is followed by the appearance of the hyperechoic fascia endothoracica on the right. That interface between pleural sliding and fascia can be mistaken for a lung point. To identify the fascia, watch for the disappearance of A lines, and depending on imaging depth, the diaphragm and liver or spleen may come into view.
The last topic we wanted to discuss in regards to evaluation of pneumothorax is lung pulse. What this refers to is the rhythmic movement of the pleural line that is in synchrony with cardiac activity. In normal aerated lung, you will not be able to see lung pulse since the pleural sliding associated with respirations is greater than the cardiac reverberations. Lung pulse is visualized here with the absence of large movements in pleural sliding that are instead replaced with small rhythmic movement consistent with the patient's heart rate. You can imagine that when initially finding this on your patient's thoracic ultrasound, the poor pleural sliding can make you concerned for the presence of a pneumothorax. However, that is not the case. The presence of a lung pulse can reassure you that this is not because of a pneumothorax. We are only able to visualize the rhythmic pleural movements because the visceral and parietal pleura are continuous. So if you see lung pulse on your thoracic ultrasound, think about whether your patient is having poor aeration in that lung either from severe atelectasis, or if they are a patient who is intubated, are they right main stemmed. Let's continue with our evaluation of the lung by next discussing B lines. As we all remember, B lines are hyperechoic artifacts that must originate from the pleural line, obliterate A lines, move with respirations, and project all the way to the far field of the screen. However, not all B lines are the same, so let's take a closer look at how we can distinguish different B lines and the pathology they are associated with. Let's first discuss diffuse B lines. Commonly when we see bilateral diffuse B lines, we think of pulmonary edema from a volume overload pathology such as heart failure or end-stage renal disease. In cardiogenic causes of diffuse B lines, you will expect the B lines not only to be bilateral, but also uniform in appearance, homogeneous, and distributed in a gravity-dependent manner, from the bases to the apex in a patient sitting upright. As we see in the clip here, the B lines in all the intercostal spaces appear homogeneous and equal in distribution, which you would also note when ultrasounding the same area on the opposite lung.
The non-cardiogenic causes of diffuse B lines, like ARDS, interstitial lung disease, pulmonary fibrosis, or viral pneumonia, frequently have some associated complexity. Often this is a pleural line abnormality. The pleural line can be thickened, more than 2 millimeters, irregular or fragmented, as seen at the arrow on the image on the left. This reflects the associated inflammation from the underlying condition. In non-cardiogenic edema, the B lines tend to be more dense and at times confluent, as seen at the arrow on the right. The distribution of B lines is often patchy, sometimes described as skip lesions, with areas of abnormal lung interspersed with normal areas. Lastly, subpleural effusion or consolidation might be seen. A final cause of B-lines that's worth mentioning is lung contusion. History is the most important factor here. A patient will present with trauma. Ultrasound may be helpful because chest x-ray does not reliably identify contusion in the first 6 hours after trauma, which may lead to inappropriate management or disposition. The B-lines in this case will be focal, isolated just to the area of injury. You'll first see disappearance of A-lines, then increasing density of B-lines as the injury evolves. At times, an associated subpleural consolidation may be seen. We actually haven't talked about the sonographic findings of consolidation yet, so we shall move forward.
That is a great segue into our final topic as we continue from our superficial to deeper thoracic ultrasound pathology with discussing subpleural consolidations. So what are subpleural consolidations? As we reviewed earlier, normal thoracic ultrasound anatomy will show a crisp pleural line that moves with respirations and the reverberation artifacts from the pleural line of A-lines on the parenchyma of the lung. Subpleural consolidations, on the other hand, are hypoechoic pleural-based collections of fluid that can appear in various shapes. These consolidations will further lead to distortions in this anatomy, which we have outlined here. The differential for subpleural consolidations is broad and depends on the clinical context in which you are evaluating your patient. As we can see in this image, the uniformity of the pleural line is lost, and there are large hypoechoic areas visualized. Further, you will notice that because of these irregularities in the pleural line, we are not seeing A-lines, and are seeing posterior non-uniform heterogeneous artifacts known as C-lines. So, when you see a subpleural consolidation, what does it mean? Let's take a look at one of the more common situations where you might see one, and that is when evaluating a patient for pneumonia. Thoracic ultrasound has numerous findings for pneumonia that you should be on the lookout for. The first being shred sign. As we see in the top left image, shred sign describes an irregular pleural line with a subpleural consolidation, most likely filled with pus or fluid in the setting of pneumonia. To the right of this image, we have a zoomed-in view of the shred sign, where the irregularity of the pleural line becomes more apparent, as do the hypoechoic subpleural consolidations. In the bottom left-hand corner, we can see the aptly named lung hepatization. When the lung begins to fill with bacteria and fluid, it begins to take on a consolidated, not aerated appearance, leading it to look very similar to ultrasonographic findings of the liver. And finally, in the bottom right image, we see our last and most commonly associated ultrasound finding of pneumonia, which are air bronchograms.
These clips both demonstrate air bronchograms. You can see them as small hyperechoic foci of air within the relatively hypoechoic lung tissue, which are now only visible because normal air in the lung has been replaced with infectious debris. The shape of an air bronchogram simply reflects the plane in which the airways are cut. On the left, the smaller, more punctate speckles reflect a transverse plane, and on the right, linear structures reflect the bronchi in longitudinal plane. There's also a distinction between static air bronchograms, seen on the left, and dynamic air bronchograms, seen on the right. Dynamic air bronchograms move with respiration, which tells you there's no bronchial obstruction and air is moving through normally. This is a good way to distinguish pneumonia from atelectasis. While both atelectasis and pneumonia can be associated with static air bronchograms, dynamic air bronchograms make pneumonia the more likely diagnosis. We covered a lot of content, but we'll leave you with a few take-home points. When in doubt about pneumothorax, use power slide, lung pulse, and lung point. Watch out for false positives, especially near the mediastinum or lung base. Lung pulse can distinguish atelectasis from pneumothorax. Non-cardiogenic B-lines will have an associated abnormality like a pleural line irregularity, subpleural effusion, or consolidation. And lastly, dynamic air bronchograms are indicative of pneumonia rather than atelectasis. With that, we've reached the end of our journey through the lung. Thank you so much for joining us. We hope that this overview was useful and provided some techniques and pointers that you can take on to your next shift.